So let's move on and talk about the relapse setting, and again, focus on some of the new data that's coming out of this meeting. But before we get into the new abstracts, just talk a little bit about your approach to early relapse, and maybe we'll start with you, Adriana. RVD light, RVD transplant, maintenance lenalidomide. A lot of our patients are on an IMiD at the time that they begin to progress. What's your approach to, I know it has to be nuanced by the individual patient, but in general, what's your approach?
What's the luxury of nuance, right? If a patient has a biochemical relapse, which I think we now have the luxury of finding much more often, I think you have the option to either re-escalate or add. So if it's a low dose of lenalidomide, I may add another agent and increase. So in the elderly patients, I like elotuzumab. They tend to tolerate it quite well. Carfilzomib, for, I think if a patient hasn't gotten it up front, as I've mentioned, most of my practice is shifting towards having had exposure to that up front. And darapom for the clinical relapse is really sort of my most used, I would say, triplet.
That's your most popular one?
Yeah.
Faith, what's your first relapse regimen?
Yeah,
of choice?
So I really like carfilzomib, pomalidomide and dex. I also, if the patient hasn't been exposed to daratumumab, then I'll have daratumumab.
What if they have? I guess most of them haven't yet.
Yeah, most of mine haven't yet. Yeah. So I certainly, in the relapse setting, have good experience of re-exposure. So my assumption would be it would work in
using a 4-drug already, KPD Dara, or just KPD or Dara? Is a choice between carfilzomib and daratumumab, or?
Unfortunately, that I haven't had the luxury of doing many 4-drug regimens, so I can't get it approved, but or reimbursed. But you can imagine that if the patient was fit, it was certainly a possibility. But I think that potentially I'm still in the 3-drug regimen in that area.
Adriana, I want to come back to something you said because I didn't challenge you on it. You continue lenalidomide and escalate the dose, or do you switch?
So in a biochemical relapse, I may maintain the IMiD and just increase the dose and add a new partner.
Have you had success with that? Because a lot of people say that hasn't been very successful. Tom?
I would say in the first relapse, go into daratumumab-based regimen. I think the Pollux data, that's Lendex versus daratumumab Lendex, or the Castor data, bortezomib dex plus or minus daratumumab, or your data from Aspire. Keith would say that those 3 regimens, if you use them first out of the gate for relapse, that patients are going to have the longest PFS from one of those 3 regimens. So usually I'm picking one of those 3.
Why are people going for, if you're refractory to an IMiD like lenalidomide, why would you keep them on an IMiD? And if so, why wouldn't you change to pomalidomide, Tom?
Oh, for me, if somebody's on lenalidomide, continuous lenalidomide, then most of the time I'm going daratumumab, bortezomib, and dexamethasone. So I am switching them from an IMiD to a proteasome inhibitor. If it's somebody that really has aggressive relapse, and we all have those patients, then it is KPD, right to KPD, or darapom dex. I think those regimens work the best in a very aggressive relapse.
Just to get slightly controversial, I've concluded that bortezomib shouldn't be used in relapse. I think the results are very weak.
Well, so if you take the Castor study, and if you look at the PFS at the first relapse, it's 27 months. It's a little better than your Aspire on median.
That's not really the question. Raphael, what do you think?
I think as I was listening just to the insightful comments here by my colleagues, one of the things that just strikes me is that...
Actually, I have to come back to challenge it. It's 20 months in the daratumumab, bortezomib dex alone was terrible. It's like 9 months or something, wasn't it?
Yeah, I don't do certainly not a double.
My point was about bortezomib.
Oh, absolutely. You and I agree.
Anyway, back to you, Raphael.
Yeah, it's the 9 months is not good. So anyway, I don't think that prior exposure should define someone as being refractory. And I think in myeloma, the re-challenge is a perfectly legitimate thing. The mechanisms of resistance are quite different. For instance, we know with the IMiDs, for instance, that most patients don't have cereblon mutations. And it seems like for most agents, whether it's PIs, IMiDs, I'm going to suggest the same is true for daratumumab, there's this just pressure that builds, and if you reach a threshold, you can kill cell, you induce apoptosis. And re-challenge, I think, is appropriate because sometimes the cells that are left behind will respond. We know that empirically. But someone was asking the question yesterday, if you induce a person with a DARA KRD transplant, then what do you treat that relapse? The only new card is POM, and you're hoping they're 11-14, so you have venetoclax. But the reality is, if there has been a significant period of time of disease control, I think all of those drugs are probably active.
There was a trial on of a triplet with pomalidomide with bortezomib, dexamethasone, the Optimism study. What did you think of that, Faith?
I think it was positive. It showed that the triplet was better than the doublet. But for me, I guess, assuming my patient has already used bortezomib, I would be wanting to move to one of the other proteasome inhibitors, being carfilzomib, or if the patient wanted an oral regime, maybe ixazomib.
Yeah, I must say in my own practice, for the longest time I was switching from bortezomib to carfilzomib and from lenalidomide to pomalidomide. The question now becomes, how do you build daratumumab into that? Do you do 4 drugs, or do you drop the proteasome inhibitor? Any thoughts on that, Adriana?
Well, having sort of lived through the addition and the expansion of our armamentarium, I used to switch only one at a time if I was able to, if it wasn't an aggressive relapse. So say from a CyBOR-D to an RVD to a KRD to POM, and sort of just switch one partner at a time. So I would still consider doing something like that. I don't feel that I would need to add all of them at once in a non-aggressive.
We do a lot of the ping pong approach. They're on an IMiD base, we switch to a proteasome inhibitor base, and back and forth. For me, with pomalidomide, the good partners that we have now are monoclonal antibodies in carfilzomib. But the monoclonal antibodies, we now have elotuzumab, pomalidomide, dexamethasone, which showed impressive results from the ELOQUENT-3 study, where the overall response rate was 56%, or 53% versus 26%, and PFS of 11 months versus 5 months. And that was actually pretty amazing. I do think that the Pomalyst in the IL-2 locally produced enhances the NK cell effect, and it works really well, much better than I expected with elotuzumab.